Invite my friend Atilla Yılmaz from Istanbul, Turkey, to give a talk about spinal cord stimulation, indications, technique, and some thought about it that may be related to peripheral nerve injury. Atilla, are you with us?
Yeah, hello everyone.
Okay, so the microphone is yours and we are eager to listen to your presentation.
Yeah, thank you so much. Yes, today we will talk about the indications and techniques of spinal cord stimulation. Yeah, you know, the spinal cord stimulation, we are implanting some electrodes to the epidural area to block the feeling pain. Actually, the all neuromodulation approach is not curing the problem. It's not a cure. We are not solving the problem. We are only suppressing the symptoms. The most biggest advantage is an adjustable and reversible approach. We don't know the exact mechanisms right now about the spinal cord stimulation, but there are some papers, there are some research about, they found some change in cortical activity, some neurochemical change, and a reduction in a component of the somatosensory evocate potentials after the spinal cord stimulation. And the oldest theory is the gate control theory. As you know, it's published at 1970s. There are some papers about the success of the spinal cord stimulation, but I need to warn you, you need to pay attention that the success means not a painless. The success means at least 50% improvement on the pain. Most of the publishers rely on this reality. If you have more than 50% improvement on pain, you may think it's a successful result. And the biggest research about that, it's more than 400 cases, and they found in 74% of the patients more than 50% relief on their pain symptoms. And so far, we have more than 300,000 cases who have spinal cord stimulation. Every year, approximately 25,000 cases we are implanting spinal cord stimulation. And the most indication right now is the failed back syndrome, as you know. And some papers claim that the spinal cord stimulation is cheaper and more effective than the revision surgeries. And we will discuss a paper about that. And in this paper, it's the follow-up duration was 6 years. It's published in 2019 and in more than 200 cases. The complication is only on 26 patients, and as I said, they found, same with the Kumar's study, they found that 74% of the patients has benefit from the surgery. And this paper is a very interesting study. They only worked on the failed back syndromes, and they prospectively evaluated 45 cases, and then gave 2 options to the patients to make a revision surgery or to implant the spinal cord stimulation. And the results is very surprising. They found 9 cases from 19 cases success rate from spinal cord stimulation, but they found only 3 cases in 26 cases success rate for revision surgery, discectomy. And they found the opioid usage is more frequent in rediscectomy, and the complication rates was so higher in rediscectomy, and 1 month later, still the complications rates was higher than the spinal cord stimulation. But as a neurosurgeon, if there is a surgical fragment, if there is a surgical residue for disc, I cannot suggest to patients, I cannot tell the patients, let's do the spinal cord stimulation. Since I'm a neurosurgeon, if there is a disc, if there is a residue, if there is a recurrence on the disc surgery, most probably I suggest to remove the fragment. But we need to know that in these studies, they rule out if there is any neurologic deficit. If there is no any deficit, they suggest to do spinal cord stimulation. And as you see, the spinal cord stimulation on these reoccurrence of the disc herniation is so much higher in spinal cord stimulation. What are the components of the spinal cord stimulation? We need electrodes, implantable pulse generator, remote control, and external pulse generator. Of course, we need an extension wire to take the patient to the trial period with external pulse generator. We can group the indications we can evaluate in 3 groups, the indications for spinal cord stimulation. The high probability of successful on pain reduction we may have on fade-back syndromes, but of course we need to rule out the surgical necessity. The second line belong to the peripheral ischemic limb pain, but since I have a really good results on peripheral vascular disease cases, I think we need to talk more about the peripheral vascular disease for spinal cord stimulation. There are 2 important things. First, the spinal cord stimulation can break the pain and the vasoconstriction chain. And the other things, if we put the spinal cord stimulation electrodes, especially around T7, T8 area, we can make sympathetic blockage. And this sympathetic blockage can result with a peripheral vasodilatation. For especially the peripheral vascular disease, most of the cardiovascular surgeons is suggesting to open these problems. But especially the interventional radiologist. But we cannot solve the problem, especially the small vessels disease. The spinal cord stimulation in such these cases is so effective. Sometimes they can salvage the limbs too. So we need to make more discussion with the cardiovascular surgeons or even with the cardiologists to refer such these cases to the spinal cord stimulation surgery, because we are not only blocking the pain, especially we may salvage the limbs too. And the third one is the complex regional pain syndrome and painful peripheral mononeuropathies and the angina, unstable angina pectoris. The moderate probability of successful pain reduction we may have on axial low back pain, pelvic pain, visceral pain syndromes of the abdomen, and the postherpetic neuralgia. For pelvic pain, I can suggest you to use the sacral stimulation instead of the spinal cord stimulation. Yes, spinal cord stimulation effective on pelvic pain, but the sacral stimulation is much more effective for pelvic pain. And the low probability is the neuropathic pain following spinal cord injury or brain injury, nerve root avulsion, nerve root destruction after intentional iatrogenic procedures, and the phantom limb pain. But I have some cases with phantom limb pain who benefit from the spinal cord stimulation. Since there is a test period for spinal cord stimulation, we can test it. Even the low probability of successful group, we may suggest to take the patients to the test period before to start to destructive like ablation surgeries. We need to know which type of pain is neuropathic and nociceptive pain. The neuropathic pain mostly is steady, burning, lancinating, like electricity or tingling, but nociceptive pain is like a dull, aching, wretched, blunt, and terrifying. And you know the spinal cord stimulation is not good to suppress the nociceptive pain. And we need to know that the spinal cord stimulation is a third step approach. We need to try everything for the cases for the patients before to decide about to suggest the spinal cord stimulation. But it's testable, non-destructive, reversible, and adjustable. We can separate in 2 parts the surgical procedure. The stage 1, we need to implant the electrodes and we need to take the patients to the trial period, at least 2 weeks by external stimulation. If the patient has at least 50% improvement on their pain, we can decide about the implant the battery. We can use 2 techniques, the percutaneous one or the surgical approach. percutaneous one approach we can do awake without general anesthesia, under local anesthesia, with the needle guidance and the C-arm fluoroscopic guidance. We need to implant the percutaneous electrodes epidural area to the related area. I'm using the double gun technique, and I'm sending 2 electrodes just like that. It's a great advantage to send the 2 electrodes from same placement. And you can do, if the patients cannot, you cannot take the patient to the prone position, you can do it in decubitus position too. Also, if there is any contraindication for percutaneous approach, you may use a laminectomy. You may do a laminectomy and put the surgical pedal. And which type of electrodes? The percutaneous one, the procedure is easy. You can do it under local anesthesia, but the most important advantage, you may do the intraoperative evaluation, and you can evaluate the position of the electrodes according to the patient's symptoms. But there is more migration risk, and there is a fibrosis risk in a percutaneous one. The surgical one, we need to do the laminectomy. We need to put it under general anesthesia, but the migration risk is lower than percutaneous one, and no restriction about the fibrosis. But since we cannot ask the patient about the effectiveness of the electrode to understand which level is good for the patient, we need to use this table about to decide the implanting the surgical pedal before the surgery. All patients should undergo under a screening trial period, at least 2 weeks, even in surgical one or percutaneous one. If the patients have at least 50% improvement, we may decide about implanting the battery. If the patient is not sure about the beneficial effect, we may increase this duration like additional 1 or 2 weeks, but we need to know that when we are increasing this trial period, the infection rates will be increased too. This patient has a left leg amputation because of the Burger disease, and on right leg, the same symptoms started. Severe pain and some necrosis, and you can see only 1 month later after the spinal cord stimulation implantation. Of course, you cannot save such these legs, such these extremities, but as I said, on peripheral ischemic vascular diseases, it's so effective treatment, the spinal cord stimulation. Another patient is with a toxic neuropathy, with a severe pain after 2 weeks, and I want to share with you these cases. 24 years old girl, she has a median nerve agenesis, and during median nerve, severe neuropathic pain, and we implanted the spinal cord stimulation, but the patient didn't want to have it under local anesthesia. We did it under general anesthesia, even with percutaneous approach. But to be sure about the placement of the electrodes, we did intraoperative neuromonitorization to be sure the electrode position is correct in the right place for the patient. And another case, 26 years old male with a shrapnel injury. We implanted 2 electrodes, but since the pain area is just exactly below the under the shrapnel area, we implanted the pedal type of electrodes retrograde from the superior to the inferior. It's not easy approach because of the angle of the spinous processes, but you can implant the retrograde epidural area. What are the contraindications? If there is a negative result in trial period, uncontrolled bleeding disorder, systemic or local sepsis, or active psychosis, uncontrolled major depression or anxiety disorder, and serious alcohol or drug addiction problems, we cannot do the spinal cord stimulation. I want to shortly look to the complication rates. The important complication is the lead migration, and we have more in percutaneous approach, especially on cervical area. Most of them is about the hardware problems. And another hardware complications risk is the loss of the connection and lead wire breakage or hardware malfunction or battery failure. You can see here the migration of the electrodes. And another interesting complication, in this case, I implanted 2 electrodes for Buerger disease on lower extremities to cover a wider area. But interestingly, the upper electrodes migrated to the cervical area, not to the down, to the up. And in very, very anatomical position, you can see here, the second one is migrated from here, from thoracic area to the cervical area. And you can see here, it's migrated. It's about the hardware. If the hardware is not good, it cannot squeeze the electrode and it can migrate. The biologic complications, the first line is belong to the infection, of course, or the patients may feel pain over implant site, erosion, allergic reactions, hematoma, cerebrospinal leak, seroma, or paralysis are so rarely SIMS. I'm using the vancomycin in all neuromodulation approach, all implantable surgeries. I'm using the vancomycin powders, and after I started to vancomycin powder, the infection rate is decreased into the very, very low area. We had 2 times cadaver course in Istanbul in 2022 and 23. And next year we will hold the 3rd one. And this time the cadaver course will be a joint meeting with the 4th MSSFN meeting conference. And all participants will have an opportunity to use all neuromodulation interventions on cadavers, and we will try to bring to North and South and East and West together in Istanbul, and we will be happy if we have you. Thank you so much.
Thank you very much for the excellent talk. Is there any question? Dr. Gokulu?
Sacral modulation had a very riddle part, even for pelvic pain or other low back pain or another, how can we say, failed back surgery. Do you want to share us, because lots of performations about implantation in the lower lumbar spine. So do you like to share your experiences about this sacral neuromodulation effects or success rate?
I cannot suggest the sacral stimulation for failed back or any other spinal problems, pain. You can use the sacral stimulation for pelvic pain, especially if there is any pudendal nerve problem. And you can use the sacral stimulation for urinary retention, for chronic constipation, like bladder or bowel problems, additional to pelvic pain. But the other pain syndromes, I suggest you to use the spinal cord stimulation instead of the sacral stimulation.
Any other question? I will then ask one more question, quite related to the previous one, but how do you fit spinal cord stimulation to get in the realm of the other neuromodulation therapies, including peripheral nerve stimulation, or, for example, multifidus stimulation for back pain? How do you fit spinal cord stimulation, or in your practice, spinal cord stimulation really is king and manage to solve most of your problems?
Sorry, I couldn't understand your question. Can you repeat it or more clear?
So how do you fit spinal cord among all the neuromodulation procedures, including spinal cord stimulation, peripheral nerve stimulation, DRG, multifidus stimulation? How is spinal cord stimulation kind of located, situated?
got it.
Do you use mostly spinal cord stimulation, or you say, no, there are certain pathology I prefer to use something else?
Yes, of course, if there is any specific local pain, it's like related by some roots or rootless. We may use, of course, the peripheral stimulation or the DRG. But if the patient is, if the pain is widely in a wide area, of course, we need to prefer the spinal cord stimulation instead of such as DRG or peripheral stimulations.
Okay, thank you very much.